Good morning, everybody. I welcome all the undergraduate students of Emma Medical College. Dr. Rajesh Patil here. Dealing with today the pathology class. The title is Autoimmune Diseases. Nowadays, we are coming across a lot of such autoimmune diseases cases. More patients suffering from such diseases, including the doctors. So, what could be the cause? What could be the background story for this? Introduction. Auto or self antigens are antigens that are present in one's own cells, which are altered by the action of bacteria, viruses, chemicals, or other drugs. The autoantibodies. What are these? These are the autoantigen that elicits the productions of antibody. Autoimmunity is defined as presence of immune reaction against self antigens. Coming to the definition proper. Autoimmunity is the failure of an organism in recognizing its own constituent parts as non-self. So it thinks it's not its own, which allows an immune response against its own cells and tissues. Any disease that results from such aberrant immune response is termed an autoimmune disease. So 2 to 3% of population will suffer from such diseases. Underlying cause of autoimmune disease is the failure of tolerance. 3 requirements for autoimmunity disorder: the presence of an autoimmune reaction specific for self antigen, evidence that such reaction is not secondary to tissue damage, absence of another well-defined cause of disease. Coming to the classification. Autoimmune diseases, the organ-specific ones. Diseases mediated by antibodies, autoimmune hemolytic anemia, autoimmune thrombocytopenias, autoimmune atrophic gastritis of pernicious anemia, myasthenia gravis, Graves' disease, Goodpasture syndrome. Now, diseases mediated by T cells, type 1, diabetes mellitus, multiple sclerosis. Now, then diseases postulated to be autoimmune, such as inflammatory bowel diseases, that's Crohn's disease, ulcerative colitis, nowadays very common one, this one, the irritable bowel syndrome cases. Primary biliary cirrhosis, chronic active hepatitis, that's autoimmune hepatitis. The systemic one, systemic lupus erythematosus, that is a butterfly rash. Usually the patient comes with at your clinic in future with a butterfly rash on the face. So that's a very classic finding. So immediately you suggest such patients for all the antibodies tests like autoimmune, like anti-nuclear antibodies, anti-DNA antibodies, anti-S, Smith antibodies, all those stuff. The systemic lupus erythematosus. Rheumatoid arthritis, systemic sclerosis, scleroderma, Sjogren syndrome, polyarthritis nodosa, inflammatory myopathies. Coming to immunological tolerance, specific unresponsive state induced by exposure to antigenic epitopes. Tolerance to self is initially induced during embryonic life and is maintained by antigen. Tolerance occurs in both T and B cells. Multiple mechanisms of tolerance exist. It is of 2 types: central tolerance, peripheral tolerance. Now, what is central tolerance 1? Central tolerance occurs through clonal deletion. Clones of cells that have receptors for self-antigens are deleted during development. Death of self-reactive T or B lymphocytes. The lymphocyte clones take place in thymus or bone marrow. So as the name indicates, T, thymus, B, bone marrow. T cells that bears receptors for self-antigen undergo apoptosis. A protein called autoimmune regulator is thought to be most important protein. It is a transcription factor necessary for presentation of peripheral antigen protein to T cells in the central lymphoid organs. Exact mechanism causing apoptosis is not fully understood. Few cells still pass in peripheral circulation. Now coming to peripheral tolerance, several mechanisms silence autoreactive T and B cells. Clonal energy, failure of APC to deliver a second signal during antigen presentation. Example, B7 CD28 interaction. Suppression of responses may occur by production of regulatory T cells that inhibit immune response to self-antigen. Example, TGF beta, interleukin 10, Th1 versus Th2 cytokines. Clonal deletion of T cells that recognize self-antigen occurs by activation, induced cell death by apoptosis, antigen sequestration. Now this is the the T cells and the B cells one, the thymic derived and the bone marrow derived one. The graphic schematic representation. Such representation are beautifully exhibited here that you should know to put it on the answer sheets when these such questions are asked in your exams, university exams. The B cell, so the receptor editing, the deletion ones. Here the T cell, antigen presenting cell, APC presenting antigens. So in the thymus, so these particular receptor being exhibited, the T cell receptor and the receptor expressed on the APC molecules, antigen presenting cells. So the development of a regulatory T cell is in the process here. So peripheral tolerance, so this was the central tolerance, this is the peripheral tolerance here. The suppression by T regulatory mechanisms, the APC presenting self-antigen, energy, that is failure to respond. Pathways to peripheral tolerance, the normal response, that is CD28, B7, proliferation and differentiation leading to activated T cells, then energy, that is antigen recognition without co-stimulation, CTL4 B7 interaction, functionally unresponsive, activation induced cell death, fast cell interaction leading to apoptosis, cytokine regulation, cytokines mediated suppression leading to inhibition of proliferation and effector action. Mechanism of autoimmunity. Autoimmunity arises from a combination of the inheritance of susceptibility genes, breakdown of self-tolerance, and environmental triggers such as infections and tissue damage, which promote the activation of self-reactive lymphocytes. So this is a schematic representation here. The contributory factor for autoimmune diseases, the environment, immune regulation, and the genes susceptibility. Genetic susceptibility, so the genes, failure of self-tolerance, self-reactive lymphocytes. So environmental stimulus, the infections, tissue injury, inflammation, action on the tissues leading to activation of tissues, the tissue antigen presenting cells, leading to influx of self-reactive lymphocytes into the tissues, causing activation of self-reactive lymphocytes. Tissue injury leading to autoimmune diseases. Now, clinical features of autoimmune diseases. So, first and foremost, we'll start to deal with individual diseases, the important one being the systemic lupus erythematosus. So, individual, it can in itself be asked for 5 marks question or a 3 marks one. The chunk of this answer can even form a 3 marks question or the answer for a 3 marks question. SLE is a clinical syndrome characterized by multi-system chronic inflammatory disease caused by deposition of immune complexes and binding of antibodies to various cells and tissues. Characteristic lesions are due to immunocomplex deposition in the skin, blood vessels, and musculoskeletal systems. Also can affect every organ, kidney, heart, central nervous system, and lungs. So here the presentation, the mala rash, the discoid rash, the photosensitivity. So the definitions, various definitions for these particular thing: oral ulcers, arthritis, serositis, renal disorder, neurologic disorder, hematologic disorder, immunologic disorder, anti-nuclear antibodies. This is very important. Anti-nuclear antibodies, an abnormal titer of anti-nuclear antibodies by immunofluorescence or an equivalent assay at any point in time and in the absence of drugs known to be associated with drug-induced lupus syndrome. So the patient has hemolytic anemia, leukopenia, lymphopenia, thrombocytopenias, seizures, psychosis, pericarditis, persistent proteinuria. So all these erythematous rashes, fixed erythema. So all these presentations here. So that is a basic representation in a tabular form of SLE. Coming to rheumatoid arthritis. So this is bread and butter of a practicing orthopedician. Rheumatoid arthritis is a systemic chronic inflammatory autoimmune disease affecting many tissues but principally attacking the joints. It causes a non-suppurative proliferative synovitis that frequently progresses to destroy articular cartilage and underlying bone with resulting disabling arthritis. When extra-articular involvement develops, for example, of the skin, heart, blood vessels, muscles, and lungs, rheumatoid arthritis may resemble lupus or scleroderma. Morphology: when presentation of antigen to T cells, T and B cell proliferation, angiogenesis lining, neutrophil accumulation in synovial fluid, that is synovitis, early pannus, that is 3 marks question also, early pannus formation. The pannus is a sheet of inflammatory granulation tissue that spreads from the synovial membrane and invades the joint. Then you have subchondral bone erosion, pannus invasion of the cartilage, the chondrocyte proliferation, laxity of ligaments, joint instability, contractures, and the systemic complications. So this is a schematic diagram here. What all changes: the macrophage in flux, the plasma cell in flux, the inflammation, the neutrophils in the joints. Symptoms and signs of rheumatoid arthritis: the fatigue, joint pain, joint stiffness, loss of joint range of motion. Many joints are affected, that is polyarthritis. Limping, joint deformity. So these are the diagrams here. Swan neck deformity, the classical one, the mallet finger. Sjogren's syndrome. Moving to next autoimmune diseases, Sjogren's syndrome. Sjogren's syndrome is a clinico-pathologic entity characterized by dry eyes, that is keratoconjunctivitis sicca, and dry mouth, that is xerostomia, resulting from immune-mediated destruction of the lacrimal and salivary glands. It occurs as an isolated disorder, primary form, also known as the Sicca syndrome, more often in association with another autoimmune disease. Rheumatoid arthritis is the most common. Others are SLE, polymyositis, systemic sclerosis, vasculitis, or thyroiditis. Clinical presentations: approximately 90% of Sjogren's syndrome cases occur in women. between the ages of 35 and 45 years, dry mouth, lack of tears, salivary glands are often enlarged as a result of lymphocytic infiltrates. Extraglandular manifestations include synovitis, pulmonary fibrosis, peripheral neuropathy, 40-fold increased risk for developing a non-Hodgkin's B-cell lymphoma. These so-called marginal zone lymphomas. So enlargement of the salivary gland, intense lymphocytic and plasma cell infiltration, that's a microscopic picture there with epithelial hyperplasia. Scleroderma, systemic sclerosis. What is this? This is also an immunologic disorder characterized by excessive fibrosis. The sclerosis word meaning is fibrosis. Remember that. In multiple tissues, obliterative vascular disease, and evidence of autoimmunity, mainly the production of multiple autoantibodies. It is commonly called scleroderma because the skin is a major target. But this disorder is better labeled systemic because lesions are present throughout the body. Okay, so you can say it could be a misnomer, the name scleroderma. So it could have been systemic derma to be in a jovial way. Cutaneous involvement is the usual presenting manifestation and eventually appears in approximately 25% of cases, but it is the visceral involvement of the gastrointestinal tract, lungs, kidneys, heart, and skeletal muscles that is responsible for most of the related morbidity and mortality. Forms of systemic sclerosis: diffuse scleroderma, skin thickening proximal to elbows and knees involving the trunk, more likely to have organ involvement. Pulmonary fibrosis and renal crisis are more common. Limited scleroderma, skin thickening is distal to elbows and knees not involving trunk, can involve perioral skin thickening, pursing of the lips, that is the pursing of the lips. Less organ involvement seen in CREST syndrome. Isolated pulmonary hypertension may also be seen. So some spelling mistakes there. Features of systemic sclerosis. So the diagram, what is CREST? C-R-E-S-T. So see there, calcinosis, Raynaud syndrome, esophageal dysmotility, sclerodactyly, telangiectasia. Now what all happens here? Calcinosis, calcium deposition, Raynaud's phenomenon, spasm of blood vessels, esophageal dysfunction here, decrease in motility of the esophagus, sclerodactyly, thickening and tightening of the skin or the fingers and hands, telangiectasis, dilatation of capillaries causing red marks on surface of skin. So the microscopic pictures here. So this is the macroscopic that pictures here, extensive deposition of dense collagen in the dermis, the extensive subcutaneous fibrosis, virtually immobilized, moving the fingers, creating a claw-like flexion deformity. So extensive collagen fibrous tissue here, fibrosis, very thinned out epidermis you can see. So renal crisis. So we can see come across the renal crisis here. Apart from that, the musculoskeletal, arthritis, carpal tunnel syndrome, contractures, polymyositis, pulmonary. So in pulmonary, there could be interstitial lung disease, isolated pulmonary hypertension, cardiac, pericardial effusion, microvascular, that is CAD, myocarditis. So what all you can do here? Anti-nuclear antibodies associated with systemic sclerosis, the DNA topoisomerase, anti-SCL70 specific anti-centromere antibody is seen in patient who has CREST syndrome. Polyarthritis nodosa, that is PAN. Coming to the next disease, polyarthritis nodosa. This is not so much asked in your exams, but still you should be aware of this. Vasculitis predominantly affecting medium arteries, defined as the main visceral arteries and their branches. Polyarthritis nodosa. Necrotizing arthritis of medium or small arteries without glomerulonephritis or vasculitis in arterioles, capillaries or venules and not associated with anti-neutrophil cytoplasmic antibodies. 30% of PAN seen in chronic hepatitis B, HBsAg, HBsAb deposits are seen in the affected vessels. Graves' disease. Graves' disease is an autoimmune disease. Thyroid is overactive. So basically this is the autoimmune disease of the thyroid gland. So most of the times it is dealt even in the endocrine system. A serious metabolic imbalance known as hyperthyroidism and thyrotoxicosis. This is caused by thyroid autoantibodies that activate the TSH receptor, thereby stimulating thyroid hormone synthesis and secretion and thyroid growth, causing a diffusely enlarged goiter. The body produces antibodies to the TSH-RS, thyroid stimulating hormone receptors. Antibodies to thyroglobulin could be seen, and to the thyroid hormones, that is T3 and T4. These antibodies bind to the TSH, which are located on the cells that produce thyroid hormone in the thyroid gland and chronically stimulate them, resulting in an abnormally high production of T3 and T4. This causes the stimulation of thyroid gland to secrete more TH, that is hyperthyroidism, resulting in exophthalmos, bulging eyes and goiter. Genetic basis. Polymorphism in immune function genes like CTLA4 and PTPN22 and HLA allele, that is HLA-DR3. Clinical features. Hyperthyroidism with diffusely enlargement of glands, infiltrative ophthalmopathy, that is exophthalmos, localized infiltrative dermopathy, that is peritibial myxedema. This is a classic representation. The features exophthalmos you can see there. The symptoms here. Common symptoms: goiter, enlarged thyroid gland which may cause a bulge in the neck. Other endocrine disorders such as diabetes, underactive adrenal gland, underactive parathyroid glands and other autoimmune disorders, fatigue, muscle weakness, weight gain. Coming to Goodpasture syndrome. It is a diffuse pulmonary hemorrhage syndrome characterized by presence of circulating autoantibodies against the basement membrane of lungs and kidney. These antibodies initiate inflammatory destruction of basement membrane of glomerulus and alveoli. Both kidney and lung involved 60 to 80% of the cases. Only kidneys involved in 40% of the cases. Lungs 10%. It initially presents with general constitutional symptoms like fever, weight loss, malaise, joint pains. What's the incidence here? 0.5% to 1.8 per million per year. Now, what are the kidney manifestations in this particular disease? The anti-glomeruli basement membrane antibodies initiate proliferative RPGN. What is that? Rapidly progressive glomerulonephritis. So, this type of kidney injury. Typically seen in young and adolescent males, age 5 to 40 years. Males are more affected, 6 times more. Clinical features: hematuria, subnephrotic proteinuria, nephritic urinary sediment, rapidly progressive renal failure and hypertension. So these are immunofluorescence here. IgG staining patterns here, linear IgG staining. Lung manifestations: Intra-alveolar hemorrhage, focal necrosis of alveolar walls, clinical features like hemoptysis, diffuse bilateral infiltrates, chest pain, breathlessness, cough, myasthenia gravis. So, it's a chronic autoimmune neuromuscular disease that affects the myoneural junction that is characterized by varying degrees of weakness of the skeletal muscles of the body. Classified as a B cell disease, autoantibodies against nicotinic acetylcholine receptors. Myasthenia gravis is caused by a defect in the transmission of nerve impulses to muscles. It occurs when normal communication between the nerve and muscle is interrupted at the neuromuscular junction, the place where nerve cells connect with the muscles they control. So, normal neuromuscular junction, and in myasthenia gravis, the diagrammatic representation here. So, here the acetylcholine in the junction there, nicotinic receptors, the muscle, the receptors, whereas here there is acetylcholine and there is antibodies against the nicotinic receptors. So, nullifying there its effect nicotinic receptors. So, acetylcholine comes and attaches to this nicotinic receptors here, whereas here there is no space for the attachment of these particular acetylcholine on the surface of the nicotinic receptors, because antibodies already are there against these nicotinic receptors, the muscle. Acetylcholine travels to the neuromuscular junction and binds to the acetylcholine receptors, which are activated and generate a muscle contraction. This is normal in a normal healthy individual. So, what happens here in the diseased patient? Prevention of the muscle contraction, because there is no attachment of this acetylcholine to the receptors of that is the nicotinic receptors. So, prevention of muscle contraction. Clinical features: fluctuating weakness that worsens with exertion and often over the course of the day. Diplopia and ptosis due to involvement of extraocular. Focal muscle involvement, that is neck, shoulder, facial, respiratory and bulbar muscles. Diplopia, that is double vision. Ptosis, drooping of eyelids. Now coming to another one important entity, autoimmune hemolytic anemia. The autoimmune hemolytic anemia is characterized by an abnormal production of antibodies that bind to antigens on the erythrocyte surface. These antibodies then leads to the destruction of RBCs, thus shortening their lifespan. In this destruction, so there is, it happens at high enough rate and exceeds the bone marrow's capacity to regenerate RBCs. The patient develops anemia and the associated signs and symptoms. So, autoimmune hemolytic anemia here can be primary, where no evidence for a secondary causative disorder exists, or secondary, in which hemolytic anemia is attributed to another systemic disease. So, systematic analysis is required because to know the genesis or to know the cause of this autoimmune hemolytic anemia in such patients. Classification: warm reacting AIHA, that is idiopathic secondary systemic lupus erythematosus, could be the cause. Immunodeficiency could be the cause. Then cold agglutinin disease, idiopathic secondary infection, malignancy. Paroxysmal cold hemoglobinuria, idiopathic secondary infection, mixed type. Drug-induced immune hemolytic anemia, that is drug-related antibody. Alloantibody-induced immune hemolytic anemia, hemolytic disease of the fetus and newborn, hemolytic transfusion reaction. Warm autoimmune hemolytic anemia, in the warm antibody type, the autoantibodies attach to and destroy red blood cells at temperatures equal to or in excess of normal body temperature. It is the most common form of autoimmune hemolytic anemia, more common among women, primarily due to extravascular hemolysis, usually associated with the development of IgG, also IgA and IgM. Antibodies bind to the surface of the RBC membrane. Antibodies is activated at warm temperature of 37 degrees Celsius. Causes may be either primary or secondary in etiology. The primary idiopathic in nature, secondary due to an underlying disease, example lymphoproliferative disorders, autoimmune disorders. Warm autoimmune hemolytic anemia, IgG binds to RBC surface antigens destructed in spleen, extravascular hemolysis. Cold autoimmune hemolytic anemia, in the cold antibody type, the autoantibodies become most active and attack red blood cells only at temperatures well below normal body temperature. Caused by cold agglutination syndrome or paroxysmal cold hemoglobinuria, mainly affects middle-aged or elderly, occurs due to the development of an IgM antibody. Antibody is active at cold temperatures 4 degrees Celsius and not usually physiologically significant. It may be either primary or secondary in etiology, primary idiopathic in nature, secondary due to an underlying disease. Cold agglutination disease, in cold temperature, IgM binds to polysaccharide region of glycoproteins on RBC surface. This triggers complement system to lyse RBC, intravascular hemolysis. If complement system fails to form membrane attack complex, when trigger is insufficient, complement proteins deposit on RBC surface. This opsonization enhances RBC phagocytosis in spleen, liver, and lungs, leading to extravascular hemolysis. So, breakdown of RBCs. Coming to another one entity, paroxysmal cold hemoglobinuria. So, paroxysmal cold hemoglobinuria is a rare type of cold antibody hemolytic anemia. So, this is another one wherein you see hemolysis. Destruction of red blood cells results from exposure to cold, it is 28 to 31 degrees. Occurs more in children. Antibody involved is IgG. RBC may be destroyed even when cold exposure is limited to a small area of the body, such as when the person drinks cold water or washes hands in cold water. Intravenous hemolysis occurs. It occurs most often after a bacterial infection, syphilis, mycoplasma pneumonia, or a viral illness. Measles, mumps, influenza. See, such patients, it's very tricky situation. Hemolysis, breakdown of RBCs whenever they drink cold drinks. Oh my God, very very bad to even for thinking in such patients. Can be caused due to vaccines as well, cold vaccines, the refrigerator vaccines also. During certain infections, microbes trigger formation of antibodies that react with P antigen of RBC surface. After the infection, these polyclonal anti-P autoantibodies binds to P antigen of RBC in cold temperature. When temperature increased, complement system lyses these RBCs. Intravascular hemolysis leading to hemoglobinuria and anemia. Mixed type autoimmune hemolytic anemia. Features similar to both those particular entities here, autoimmune hemolytic anemias again, and then the cold one. Both IgG and C3d are detected, the complements one. IgG warm antibodies, C3d activated by IgM cold autoantibodies. Idiopathic, secondary where? Lymphoproliferative disorders, the autoimmune disorders. Drug induced immune hemolytic anemias, antibodies directed against or one of its metabolites. All may involve IgG and C3. Hemolysis usually follows large intravenous doses of the offending drug. Occurs 1 to 2 weeks after therapy is initiated. The diagnosis depends on clinical signs and symptoms like fatigue, pallor, jaundice, shortness of breath, weakness, or inability to do physical activity. Heart failure, Raynaud's phenomenon, that is vascular occlusion necrosis in cold agglutinin disease, enlarged spleen, enlarged liver. Immune thrombocytopenia ITP is the most frequent cause of acquired thrombocytopenia in children. It is caused by platelet destruction by autoantibodies. IgG antibodies are directed against platelet membrane glycoproteins, that is GP2B3A, GP1B9 complexes. An episode may be preceded by a viral infection. Thrombocytopenia is not associated with significant lymphadenopathy and hepatosplenomegaly. Anemia and neutropenia are absent. A non-blanching, non-palpable petechial rash in a patient with thrombocytopenia. Clinical features: mucocutaneous bleeding, oral mucosa, gastrointestinal one, heavy menstrual bleeding, petechiae, ecchymosis. Tests: peripheral smear, the basic fundamental one. Low platelet count, large, huge, giant platelets can be seen. Bone marrow, increased megakaryocytes, clot retraction, which depend on platelet are normal here. Thank you. So that concludes today's topic. So this is an important one topic that you should all be aware of, the autoimmune diseases. So not only important from the clinical point of view, when you become future physicians or the treating surgeons or anyone, any specialty. So this is very important on autoimmune diseases, and even from the university RGHS exams also commonly asked question, the invariably 5 marks question category, very much you can expect such question from this particular topic. So myself, Dr. Rajesh Patil here, signing off and concluding this particular session. Thank you, all of you.